Welcome back to the Deep Dive. So, today's Deep Dive is adapted from a really insightful clinician-written article on Mentalyc, that's Mentalyca. We're bringing it to life in audio for all you licensed therapists who, prefer listening and reflecting while you're on the go.
Exactly. And this essential guide was written by Courtney Gardner, MSW. We're really honored to feature their perspective on such a critical clinical topic.
Yeah, the intersection of risk assessment, rationale, and of course, documentation. And if you happen to be new to Mentalyc, it's a clinical intelligence platform. It's built specifically to support therapists with ethical, compliant, and efficient documentation.
Right. They really get that for us, the documentation isn't just paperwork. It's an extension of our clinical care.
It really is.
And, let's start with a moment that I think every clinician knows intimately.
Oh, yeah.
You're in that systematic inquiry, right? That difficult, often really heavy conversation where you were just so present with a client trying to gauge their immediate safety.
Totally focused.
Ideation, plan means intent. It takes just intense focus.
Right, but that inquiry, that's really only half the battle, isn't it?
Not even half.
Because the real professional stress, the one that can feel, legally and ethically precarious, it often hits the moment the session ends.
That's it.
It's that moment you have to translate this profoundly nuanced, high-stakes conversation into a defensible note. You have to explain why you decided the risk level was what it was.
And if you decide they are low risk, where's the documented evidence? Where's the proof of that decision-making process?
That's the core conflict, isn't it? Clinical diligence versus documentation compliance.
It is. And the article drives home a crucial point, that risk assessment is so much more than just assessing for suicide.
That's a key distinction.
Yeah.
I think it can get overlooked in the rush of, immediate crisis management. So what are the other dimensions the article stresses we need to systematically address?
Well, it advocates for a really comprehensive safety assessment. So beyond just self-harm or suicide, we have to systematically inquire about potential harm to others, of course, but also these critical areas like self-care and neglect.
Neglect, that's often a blind spot.
It is. We need to actually document our assessment of medication compliance, living situation safety, nutritional intake, even basic hygiene.
All of it.
And finally, we have to look at major impulsive behaviors, whether that's, increased risky substance use, reckless driving, or sudden irreversible decisions.
All of those factors interact. They define the true risk landscape.
Right. So if you look at all those dimensions, it becomes clear pretty quickly that a single numerical score from a checklist just isn't enough.
We're all taught tools like the SAD person scale or the C-SSRS in grad school, and they're foundational. But the critique here is about over-relying on that score.
Precisely. The core insight, and this is echoed by international bodies like the NICE guidelines in the UK, is that we have to use these tools to inform.
But never replace.
But never replace structured clinical judgment. Tools give us data points. They don't give us the clinical rationale.
Okay, so let's dwell on that distinction for a second. Tools versus structured clinical judgment, or SCJ. For the therapist listening, why does the article insist SCJ is superior? Especially when, a legal review might happen.
Because a checklist is static, and it's often culturally blind. SCJ is that critical analytical process of weighting the data based on the client's history, their current mental status, protective factors, relational context.
So it's the whole picture.
It's the whole picture. For instance, the C-SSRS might give a high score for a history of ideation, but your SCJ might determine the immediate risk is lower if there's a strong, new protective factor.
Like a commitment to a new pet or a shift in a relationship.
Exactly. And your documentation has to reflect that exact weighting process. You can't just write down the high score and then low risk.
You have to show your work.
You have to show your work. And that leads us directly into what the author calls the documentation disaster, which is that common high-stakes mistake of just writing a risk level low, moderate, high without a clear documented rationale explaining why.
So this is about the difference between recording an outcome and documenting a process. What does a defensible rationale actually look like? What specific things do we need to capture?
It requires detail and specificity. It has to have 3 key elements. First, a clear list of identified risk factors, recent loss, financial stress,
Access to means.
Access to means. Second, and crucially, an equally clear list of protective factors that you weighed against those risks.
So supportive family, reasons for living, that sort of thing.
Right. Religious conviction, commitment to therapy, negative screens for means.
Okay, and what's the third element?
The third is the specific interventions you implemented based on that weighting. If you assessed the risk as moderate, you have to document precisely what safety steps you took.
Like initiating a safety plan or
Yeah.
contacting a resource.
Exactly. Or increasing session frequency. And if you didn't do an intervention, you need to document the clinical reason why.
So risk factors, protective factors, interventions. That full circle is your rationale.
That's your rationale.
That makes the note so much more about the clinician's rigorous decision process. Now, the article also mentions specific approaches, like the case method. What does that add that a checklist might miss?
The case approach is fascinating. It doesn't just ask about current ideation. It systematically charts the history of ideation behavior and intent over time.
So past, recent, and current.
The whole timeline. And that chronological context is so often what's missing when we rush.
Ah,
A client might say they have passive ideation today, which looks low risk on the C-SSRS. But if the case approach reveals they had a plan and attempted suicide 6 weeks ago, that context dramatically changes your SCJ.
it gives you the depth to really understand their relationship with ideation.
Absolutely. And understanding that relationship is key to avoiding another major trap the author highlights, the "they seem better" trap. We as clinicians, we get so relieved when depression seems to lift. We want to see progress, but that relief can mask an increased danger.
Right, the paradox that risk can actually increase when depression starts to lift. Let's unpack the mechanics of that.
Clinically, it's all about energy and motivation. Severe depression often comes with psychomotor retardation.
The client is just lethargic, fatigued.
Exactly. They're physically unable to follow through on plans, even if the ideation was high. But as treatment progresses, maybe medication starts working, that lethargy dissipates.
And they regain the energy.
They regain the energy and the capacity to execute the plans they might have been holding on to.
So the dangerous moment isn't the absolute bottom, it's the moment they gain agency back.
That's it. It just emphasizes the critical need for ongoing diligent reassessment, even when the surface looks better.
Your documentation has to reflect that dynamic tracking, not just a static snapshot.
Exactly.
And this is where technology, when it's designed for clinicians, can really help bridge that gap between the session and the documentation.
Yeah, the article talks about how a clinical intelligence platform like Mentalyc supports ethical documentation through features designed for this kind of vigilance.
It's like its high-risk detection feature.
Mm-hmm.
So how does that actually translate into support? I mean, we're not talking about a diagnosis tool, but a
Right.
support for our diligence, right?
Exactly. It augments diligence. It's not a replacement. The platform can analyze patterns captured in objective session data, looking at subtle shifts in language, maybe topic frequency over time, and it gently flags these concerning trends.
So if it notices patterns related to, say, hopelessness, or an increase in references to finalizing things,
Right. It can then remind the clinician to create or update the safety plan before the note is finalized.
so it's acting as that objective check on the blind spots that human emotion or just, fatigue might introduce.
Yes. It helps ensure that the rationale and the necessary diligence get integrated into the documentation before that session record is closed.
Preventing the documentation disaster from just a simple oversight.
The goal is just to make sure your notes reflect the actual high quality of the clinical work you performed.
Quick pause here. If the pressure of documentation, tracking subtle risk signals, and making sure your rationale is crystal clear across sessions feels familiar, Mentalyc, that's Mentalyc, can help. Its AI note taker supports your documentation and clinical judgment by capturing the objective foundation of the session, and it stays fully ASHI-PAY and SOC2 compliant. You can explore how this clinical intelligence platform works at Mentalyc.com.
Okay, so let's pivot to the most actionable takeaway from the source material. This is critical for both client safety and for strengthening the therapeutic alliance.
And that's the concept of collaborative safety planning.
Yes. The article really stresses moving away from relying on that thing we often hear in a high-pressure assessment.
The client's promise, I won't do anything.
Oh, right. And that promise is so often given out of exhaustion or just a desire to end the conversation.
It's clinically unsound as a protective factor.
Completely. It places the entire burden back onto the client in their most vulnerable moment. True protection lies in collaborative safety planning. It shifts the focus from just promising not to act to providing specific, detailed, actionable alternatives for when they're in crisis.
It's an empowerment model. It turns the safety plan from a document of compliance into a tool of agency. So what are the essential components that we have to detail in that collaborative process?
The author details a really structured process, one that ensures the plan is actually functional in a crisis state.
Let's walk through that structure. I think this is the most practical skill update for our listeners.
Okay, so first, we need to collaboratively identify triggers and warning signs.
Which is harder than it sounds.
So much harder. We have to define precisely what the onset of a crisis feels like for them. Is it an increased heart rate? A specific song? Withdrawal? They're personalized alarm bells.
Right. Getting beyond the abstract, I feel sad, to the physical and behavioral signs. What's next?
The second step is internal coping strategies, things they can do immediately without contacting anyone to de-escalate.
Like grounding techniques or a specific playlist.
Yes. Or engaging in a sensory distraction like holding ice. And you have to document these details because in a crisis, decision-making just collapses.
So in the note, the clinician has to list the specific techniques discussed, not just discuss coping skills.
Exactly. Step 3 is supportive contacts. This moves external, but still in their personal circle.
You list names, numbers.
And why that person is helpful. Is it for distraction? For emotional containment? Practical help?
Okay, and then the last two layers, professional and emergency contacts.
That's the most external layer. Fourth is listing professional resources crisis hotlines, community mental health centers. And fifth, the emergency layer, when to call 988 or 911. The article stresses that this structured, multi-layered approach, when it's clearly documented, is the highest standard of care. It reflects your complete SCJ.
This whole discussion really just reinforces that good risk assessment isn't about achieving absolute certainty.
Which is impossible.
It's about demonstrating consistent, rationale-driven care. And it's a heavy burden we carry.
It is. And the source acknowledges that inherent difficulty. It has this moment of shared vulnerability, observing, you may leave some sessions wondering whether you did enough, and that uncertainty is part of the work.
Yeah.
What matters is showing up fully, applying that structured judgment, and meticulously documenting your informed response.
So if you want support ensuring your clinical reasoning and protective measures are thoroughly captured, especially with moderate or high-risk cases.
Right, that's where clinical intelligence can assist. Mentalyc's AI note-taker can generate that objective, detailed foundation you need to build a clear, defensible rationale.
It reduces the documentation burden, lets you focus your mental energy on the complex human conversation happening in the room.
Exactly.
So that leads us to our final provocative thought for you to consider. The ultimate goal, really, isn't to perfectly predict outcomes. That's impossible. It's to perfectly document our informed, compassionate response. So with that in mind, how might focusing solely on documenting why you made a decision, the rationale,
Yeah.
how might that shift your focus and your presence during the session itself?
Yeah.
Could it actually encourage even greater clinical rigor right there in the moment?